Welcome to another EduMed video. This is the first of a series of videos looking at Airway Pressure Release Ventilation, or APRV. The first few videos in this series are going to focus on the basics and give you some rules of thumb. The last video will be a more in-depth video that will go through some of the advanced techniques and some of the nuances of APRV. So don't worry if the first few videos seem a bit oversimplified. The reason for this is just to give an introduction and a basic understanding of what APRV is, so that if someone needs to start it quickly, then they can do, and use general rules of thumb to manage a patient effectively with APRV whilst waiting for someone more experienced to come and give them a hand. In this presentation, we'll talk a little bit about what Airway Pressure Release Ventilation, or APRV, is, why it's useful in severe respiratory failure, and how to actually start someone on APRV. So before you watch this series, I'd really highly recommend you watch my series of videos introducing ventilation and understanding what the mechanics of ventilation are and what the aims of mechanical ventilation are. For those of you who have watched that video, you will know that the most important thing is this picture here. It is conceptualizing what is happening in the lung. And the lung is essentially made up of two parts. There is the alveolus, which has to be full of gas, and there has to be a blood supply coming into the alveolus and around the alveolus so that it can cause gas exchange between the blood and the air. Oxygen will diffuse into the bloodstream as long as the concentration of oxygen is higher in the alveolus compared to in the capillary. And similarly, carbon dioxide will passively diffuse out of the capillary and into the alveolus as long as the alveolus is patent and there is blood flow through. These are the two basic principles of any form of ventilation. And if we are mechanically ventilating a patient, it is usually because they have one form of respiratory failure, where essentially they're not able to provide enough oxygenation, or they're not able to get rid of carbon dioxide, or usually a combination of both. Again, please go and have a look at the videos which go into this in a lot more depth, but essentially, oxygenation purely depends on four things. And so there's only really four things that you can adjust to try and improve oxygenation. If these four things are not able to be improved any more than you have done, then you need to think about other methods of oxygenation, such as ECMO, extracorporeal membrane oxygenation. So what are those four things? Well, the first thing is something very intuitive to any doctor or nurse looking after a patient. If you've got someone who's hypoxic, you increase the amount of oxygen that they're breathing, i.e. you increase their fractional inspired oxygen concentration. On the ward, that would be to increase the nasal specs from 1 litre up to 4 litres, or then putting them onto a mask, and finally onto a non-rebreathe mask. With the ventilator, it's simply a matter of increasing up the amount of oxygen that's put into the gas mixture that goes through the endotracheal tube and into the lungs. The fundamental point of positive pressure ventilation is to try and open up alveoli so that you can improve oxygenation. That is why positive pressure ventilation is the next step up from adding oxygen on using a non-rebreathe bag. And if you remember back to my last lectures on the basics of ventilation, you will know that an alveolus, as long as it is open, it'll continuously diffuse oxygen from the alveolus into the blood supply, as long as there is that concentration gradient. It doesn't matter whether the patient is in inspiration or expiration, it'll continuously cause oxygenation of the blood as long as the alveolus is open and there is blood flow going through the capillary. And as such, there is the concept of PEEP, positive and expiratory pressure. This is very simply a pneumatic splint, a way of keeping the alveoli open during the expiratory phase for the patient. Now, a very simple method of this, which you might see with non-invasive ventilation, is something called CPAP, continuous positive pressure airway pressure. And essentially what this is akin to you driving in your car and sticking your head out of the window. Suddenly you'll get a rush of air and you'll get the lungs expanding up that little bit more. You're still breathing on top, but your lungs just expand up, and that's exactly what PEEP is. Trying to open up as many alveolar units as possible. You must always remember that the second half of ventilation is lung perfusion. If you have impaired cardiac output, or you over-distend the alveoli such that it pinches off the capillaries so there's not enough blood flow going through, doesn't matter how good the gas is that's in the alveolus, it won't be getting into the blood supply, and therefore the patient will be rendered hypoxic. So you must always maximize alveolar blood flow and think about cardiac output and pulmonary arterial resistance. The final thing that needs improving is the blood-alveolar interface. This is what's usually the problem in disease states like pneumonia. The lungs will fill up with pus, or they become edematous with inflammation or with fluid in with heart failure. And so the distance between the alveolar gas and the capillary increases with exudate and with inflammation, so that the diffusion of oxygen across that interface becomes harder, and so patients have less efficient gas exchange. And so all you do with positive pressure ventilation is you buy a bit of time until the underlying disease, be that infection or fluid, is resolved with the treatments like antibiotics or diuretics. Carbon dioxide really only depends upon two things in either conventional ventilation or with spontaneous breathing. And again, you can think about it in terms of the alveolus and in terms of the blood flow. Obviously, you need to maximize blood flow in order to allow the blood to go through and to exchange the carbon dioxide out. But in terms of the alveolus itself, it depends purely upon two things: the respiratory rate of the patient and the tidal volume. And minute ventilation is a function of both of those. So it's minute ventilation is respiratory rate multiplied by tidal volume. The higher the minute ventilation, the more carbon dioxide that's released from the body. Now I want you to just think for a second about a patient who is not breathing at all. You've got a tube going from the mouth down into the trachea. If you imagine blood flowing through the lungs and therefore gas diffusing out into the alveolus, the concentration of carbon dioxide in the alveolus is going to get higher and higher. The end of the tube that's sitting in the mouth is going to be open to the air, where there's very little to no carbon dioxide. Now, if you think about the diffusion of any gas, it'll always go down a concentration gradient. So if you've got a continuous tube, continuous column of gas going into the alveolus from the mouth, and you've got a high concentration of carbon dioxide in the alveolus, naturally it'll have a tendency to diffuse out and into the air through the tube. And this is what we call diffusion removal of carbon dioxide. Generally, in conventional ventilation and with normal spontaneous breathing, it doesn't play a huge part because you're usually breathing in and out, and the so-called bulk movement of gases is the most important part of removing CO2. However, as you'll see as we talk a little bit about APRV, you'll realize that this becomes a much more important component of CO2 removal and actually becomes an additional thing that can be used to improve CO2 removal. And we'll go into a lot more detail about that in a future video. So the first question is, what is APRV? APRV stands for Airway Pressure Release Ventilation. And the best way to think about it is that it is an extreme form of CPAP. It's just CPAP with a little bit of additional stuff that's done to it to help with CO2 removal. So what is CPAP? Continuous positive airway pressure. This is you driving down the motorway at 70 miles an hour, you stick your head out of the window and your lungs just fill up. Why is that useful? Well, you're providing a pneumatic splint, so all of those bits of alveoli that are squashed and collapsed because of the abdominal contents pushing up on the lungs from the mediastinal contents, such as the heart and the great vessels pushing down on the lungs, and the natural tendency of the rib cage to collapse in on itself, especially if a patient is paralyzed. For all of those things, by collapsing those alveolar units, you're not going to maximize the amount of oxygen getting into the blood. So you want to recruit up as many alveoli as possible. And that's the central theory of how you can use APRV to help with oxygenation. You are trying to open up as many alveolar units as possible. And you want to try and keep them held open for as long as possible. So at its very simplest, it is just having a very high pressure all the time, opening up all those alveolar units, popping them all open. And you can see that here. If you imagine you've got a high pressure, so let's say a pressure of 20 centimeters of water constantly going into the lungs, it'll slowly open up all of the small collapsed alveoli. Now on top of that, the patient's going to be continuing to breathe. Now, another really important concept in APRV is that of lung compliance. I want you to take a little while to just have a look at this graph here. This is a so-called volume pressure graph, and what it's giving you an idea of is lung compliance. If you imagine for a second blowing up a balloon, when you're first starting to blow up that balloon, even though you're blowing really hard, the balloon doesn't really change its volume too much. And then, once it's expanded up to a certain point, you suddenly find it really easy to start blowing the balloon up more and more and more, until again you get to a point where the balloon is so full that even using the same amount of pressure, you just don't get any more expansion of the lung, or the balloon in this case. And this is exactly what this graph is showing. So if you follow the solid curve first, this is inflation or inspiring, expanding out the lungs. For the first part, you're generating a big change in pressure, but the volume hasn't changed at all. And then slowly, you find that for much smaller increases in pressure, you're starting to get bigger changes in volume. And then you get to that upward sloping point, from the lower inflection point to the upper inflection point. And you can see here that even just a small change in the pressure actually gives you a big change in volume. And this is the part of the curve that we want to be on, where we maximize the efficiency of the lungs, expanding and therefore making it easier for the patient to breathe. Now, as you get sick, as your lungs become sodden with fluid in pulmonary edema, or in patients who have a bad pneumonia, what you find is their lung compliance goes down. Their lung becomes soggy and stiff. And therefore, this curve flattens out and moves over to the right-hand side. What does that mean in reality? What it means in reality is you need a bigger pressure before you can start taking an easy breath in. And you clinically have probably seen this if you've ever looked after a patient with pulmonary edema and they're really struggling to breathe, and then you put on a CPAP mask for them, and within 5-10 minutes, suddenly they're finding it so much easier to take those breaths in. Now, people think that that's because, you're just forcing water into the lungs again. Well, it's not really that. all it is that you've moved the patient up the compliance curve. You've suddenly made it that much easier for them to breathe. And the way to think about that is, again, imagine yourself driving in a car, driving at 5 miles an hour, and then you stick your head out the window. Suddenly you get that little rush of air coming into the lungs, and they expand out a little bit more, and it suddenly becomes a lot easier to breathe in and out. Now, if you keep going and you keep accelerating, you'll move up that compliance curve to that shoulder point, the upper inflection point. And so then if, say, you're driving at 40, 50, 60 miles an hour, suddenly your lungs feel over-distended, and again, you find it difficult to breathe. So for most patients, what you want to try and do is to get between that lower and upper inflection point, and to start off at that area so that it's easiest for the patients to breathe, and you need the little amount of pressure as possible to expand the lungs up and to let them collapse down. And so this is where PEEP again becomes very useful for patients. And CPAP is, and APRV is what we can use to continuously keep a patient who's got really bad lungs, severe respiratory failure, at that point between the upper and lower inflection points for as long as possible. So it can actually really improve the efficiency of the lungs. So if thinking about just purely oxygenation of patients, you realise that actually you've got two things that you're going to be changing. So you can change the amount of oxygen that the patient breathes in with the gas, and you can change their PEEP or their P high. This is the pressure at which you continuously keep the patient at to keep those alveoli open. Now, what's the problem with just keeping a patient on a very high CPAP, which is what APRV essentially is? Well, the problem is CO2 clearance. Now, we talked a little bit about diffusive clearance of CO2, and that does play a part. And you will find actually that by getting the patient on the right amount of CPAP, you do improve their CO2 clearance, and it's probably partly related to the diffusive clearance of CO2. However, often we find that this is not enough, especially in patients who are septic, hypermetabolic, and therefore have high CO2 production. And so for those, we need to try and improve their minute volume. How do you improve their minute volume? Well, you need to increase the bulk flow of gas coming out. And this is where the nuance of APRV comes in. In addition to the continuous high pressure to keep the lungs open, we also need to find some way of getting rid of gas every so often so that we can clear or wash out the lungs of the carbon dioxide. So it's not just full of high carbon dioxide, high oxygen gas. And this is what we do in APRV. We do something called pressure releases. So if you look at the graph, you can see there the P high in the green. That is the so-called high pressure that we keep the lungs at, so we keep all the alveoli open and maximize oxygenation of the patients. And you do that for a period of time, and that period of time is called the T high, or the time that it's the high pressure. Then every so often, the ventilator just drops that pressure off. And if you look at the flow graph on the bottom, you can see suddenly there's a big flow of gas. And that big flow of gas is a release of that pressure, so effectively letting everything recoil back and bulk movement of air or the ventilatory gas out of the endotracheal tube. And then suddenly the pressure goes back up again to keep those alveoli open and the lungs expanded to try and improve oxygenation. Now you can really improve the CO2 clearance by actually keeping the patient spontaneously breathing. And if you look at the second one of those CPAP phases and look at the flow graph on the bottom, you can see during those spontaneous breaths, the patient's actually moving some more gas. So you're improving the patient's minute ventilation. You're not just relying on those release phases to release those big flows of gas and i.e. wash out the CO2. So if you look at the graph of what happens with APRV, you can also start to get an idea of what you can set in APRV. As with all ventilatory modes, you can set the inspired fraction of oxygen. Now the second thing that you can set is the P high. This is effectively the level of CPAP that you're giving the patient to keep the lungs open. And because the ventilator needs to know how long you're going to keep it on for, that high pressure, that's called the T high. Then every so often you want the ventilator to release that pressure so that you can get a bulk movement of carbon dioxide rich air out of the lungs. And so that is the P low is the pressure it drops down to, and then for the amount of time that it drops the pressure down is the T low. So those are the only 5 things that you need to set for APRV. And actually it becomes even more simple than that, because the settings are all pretty much fixed for a patient for a given disease state at a given time. So I would really recommend you watch my advanced video to actually work out the exact patient-specific, patient-tailored settings for APRV. But what I'm going to give here is for the most part what people start with for APRV in patients who have severe respiratory failure. So usually those patients with an FiO2 of greater than 60% on conventional ventilation. Whenever you're starting a patient on a new mode of ventilation, there's a chance that they could deteriorate. So I tend to start them on 100% oxygen, then slowly wean them down once you've established them on it. So start off on 100%. The P high is that high pressure that you want to keep the lungs nice and expanded. Generally speaking, do not go above 30 centimeters of water. Most people set a limit in their heads of 25 centimeters of water. You can start between 20 and 25 for most patients. Be wary, especially if a patient is hemodynamically unstable, if they're hypotensive, because if you suddenly increase the intrathoracic pressure, you can decrease venous return to the right side of the heart. So sometimes starting even lower at 15 centimeters of water as the P high and then slowly working your way up could also help. But generally speaking, during the worst part of a patient's respiratory failure, you're around the 20 to 30 mark in terms of the high pressure. In terms of the time that a patient is kept at that high pressure, it's generally speaking between 4 and 5 seconds. Sometimes, if the patient's got a lot of carbon dioxide on board, you can drop their T high down to around 3 seconds, 3 to 3.5 seconds. But the whole point of APRV is to try and maximize the amount of time that the lungs are open. And in order to do that, you want to try and maximize the amount of time that you're at that high pressure. Now, for all patients, you should set a P low as it goes. So this is the low pressure. You should aim for 0 if your ventilator allows it. Some ventilators are preset to a minimum P low of 5, but basically turn it down to the lowest that you can get. Again, we'll go through that in a lot more detail as to why that's the case in the advanced video on APRV. But when you're just starting off, just know that it should be set at the lowest that you can physically get it at for that particular ventilator. And the T low is generally between 0.3 and 0.5 seconds, so quite short. And again, the reasoning for that I'll go through in the more advanced video, but essentially the reason you keep it that short is to try and maintain the recruitment that you've achieved of all those small alveoli during your period of P high, your high pressure. So what I hope I've gone through in this is what actually APRV is, and the initial settings that you would start for a generic patient. Like I say, you can tailor those settings much more, and I'll go through that in detail in the advanced lecture. But for the most part, the settings that I've put out on the last slide would work with most patients. Please keep watching because I'm going to be providing a whole series of videos on APRV made easy, each one attacking a certain area of the management of a patient on APRV. And like I say, the advanced lecture that I'll produce at the end of this series will really go into some of the nuances of APRV, which are more difficult to explain in a short video. Well, I hope that you found that useful. And if you did, please like and subscribe to the channel and hit the bell notification. You'll see quite a lot of these videos coming out over the next few weeks to months. Thank you very much, and hopefully I'll see you next time.